It's a pleasure to be moderating this session, and it's a topic that we've touched upon several times today, and a few of you have also been already on the stage today. But we're going to dive into more details of enhancing patient care with pharmacogenomics, from the science to the applications to the specific Emirati genome application in the UAE. Dr. Val, can you get us started with the science of pharmacogenomics? What is pharmacogenomics?
Good afternoon, everybody. The first association with pharmacogenetics dates back to 510 BC, when Pythagoras noted that when selected individuals consumed fava beans, the effect was fatal. But not everybody died because of the consuming fava beans. Now we know it's connected to the enzyme G6PD. And term in pharmacogenetics was introduced in 1957, and this term was introduced to highlight the connection between our genetics makeup and interactions with pharmaceutical agents. But recently, term pharmacogenetics was replaced with the term of pharmacogenomics. Pharmacogenomics, it's a field of study which researches our interactions of our makeup and the pharmaceutical agents. And because of the recent advances in our knowledge, the knowledge of when we sequence whole genome sequencing, now we know that our interactions with the drugs depends on the certain haplotypes, the combination of star alleles. And these star alleles, they differ in each individuals, and they actually define our ability to metabolize the drug. Now we know that there are several type of metabolizers, and around, I think, 5 to 10% we have ultra-rapid metabolizers, those people who metabolize the drug really quickly, and for those people, we have to prescribe increased dosage. Then majority of people, I think maybe 65 to 80%, there are extensive metabolizers when they react normally to the prescribed dose of the drug. Then we also have intermediate metabolizers, which has slow metabolism for the prescribed medication. So in these cases, we need or to replace the medication or reduce the dosage. And then we also have slow metabolizers. The slow metabolizers, it's really 5 to 10%, I think, within the group of population. Those people, they have a risk of toxic effect because even when you use a regular dose, because the metabolization of the drugs go really slow. So with this knowledge, I think now we're working towards implementation of our knowledge into practice.
Thank you. Thank you for the fantastic overview. And looking at Sahar, you're leading one of the, or the largest, that is, a rollout of the Emirati Genome Program, which is a very ambitious initiative and one of the largest scales. Can you tell us a little bit about the vision behind this program?
So the Emirati Genome Program is the national genome program of the UAE, and one of the goals of launching this program is to be able to gain insights into what makes our population unique when it comes to their genetic makeup. A lot of what we know about genomics is based off of studies that were done in Western population, and what might apply to them might not necessarily apply to us. So with pharmacogenomics, what we aim to do within Department of Health is to allow healthcare professionals and healthcare providers to make evidence-based approaches when it comes to selection of treatment for their patients. We're moving away from a one-size-fits-all model to a more personalized model when it comes to treatment selection. Through a proof of concept study that was done with one of our partners, we found that in the Emirati population, about approximately 47% were carriers for a actionable finding when it came to medication response. And so what we aim to do is allow for, before prescribing a medication, we're able to account for factors that are related to genetic makeup to ensure that we're not prescribing treatment that would cause adverse side effects, or be able to tailor the dosage specifically to ensure that the patient is metabolizing and benefiting from it effectively.
Thank you. It's fantastic to see this program rolled out. And Dr. Asma, Dr. Amal, as the scientific chairperson and from a clinical pharmacy perspective, Dr. Val already touched upon some of the concepts of pharmacogenomics and the different metabolism with different patients. Can you add to that? Can you comment on that, please?
Sure. Genetic variability affect the metabolism for every individual. So some people will have, as a doctor said, a slow metabolizer, and the others will have a rapid metabolizer. This means the patients need individualized medication, personalized medicine, as the term used nowadays. So for the patients with a slow metabolism or metabolizer, the medicine will stay in their body for longer time, and this will lead to overdose or toxicity or side effects. On the other hand, if the patient have a rapid metabolizer, the medication will not give the needed or intended effect. So we need to implement the pharmacogenomic testing in order to give the right dose, the right drug for the patient. We can give an example for warfarin, which is a blood thinner, because it have more than one genetic affected by the as metabolizer. So if we are giving the standard dose of warfarin, some patients have risk of toxicity, and others will not have the exact or right dose they need. So this genetic variability and pharmacogenomic testing is important and crucial because it's help the healthcare providers and the clinician to select the right medication for the patients, and in order to optimize the therapy outcome and minimize the risk effect of the medication.
Thank you. And of course, for that concept to also work, it's important to really understand the data, the ancestry data of the UAE with its complex and diverse population. Dr. Wadha, can you elaborate on that within the context of the UAE, please?
Say it again.
The understanding the data of our ancestors through the Emirati Genome Program.
Sure. So understanding the local ancestry data is essential to have a successful pharmacogenomic program within UAE, and it actually reminded me of the first pharmacogenomic report draft that we received from M42. So we were reviewing basically the pharmacogenomic list and looking into the genes included within the report. So we were hesitant to include one of the pharmacogenes because we know that the recommendation from the CPIC guidelines were optional. However, we knew for a fact that they were optional because there was not enough clinical trials, and we knew as well that the allele frequency in South Asian accounted for 30%. However, it was nearly absent in another ethnicity. So with the help of M42 and the expert from Khalifa University, we were able to analyze the EGP cohort as well as utilizing the Emirati reference genome platform to figure out the allele frequency among the Emirati population. So we found that it is accounting for 41%. So that make us confident to include it within our pharmacogenomic list and report. So the program will be more tailored to the Emirati population and will enhance the therapeutic outcome.
And it's very interesting to see, to understand pharmacogenomics as a concept beyond just the academic part of it. A question to Dr. Grobmyer on cancer therapy. And cancer, for me, it hit close to home. My father actually was a cancer patient, and I recall that he was actually more afraid of chemotherapy than he was afraid of the disease itself. How do you see the applications of pharmacogenomics and alleviating some of these concerns and potentially making this therapy safer for patients?
Oh, thank you for the question. I think we need to take one step back and look at what's being done here is so unique. And then I'll address the issue in oncology specifically. Traditionally, and still in most places these days, pharmacogenomics is not routinely used. What happens in routine clinical practice in the United States is a patient's given a drug, and then they have a very severe reaction, and then the doctor thinks, oh, maybe this is related to abnormal metabolism of the drug, so the doctor then orders the pharmacogenomic profile and then may determine that the severe reaction is due to abnormal metabolism. So that's a reactive approach. But with what's behind the mRNA Genome Project now, we are converting this into a proactive approach. So there's actually a circular now from the Department of Health, which requires physicians in Abu Dhabi who are ordering medication that's on the list of medications affected by the pharmacogenome to order the test preemptively, with the idea being that we can then work to lower the dose or adjust the dose and make the treatment more effective and less toxic. In oncology, there are many drugs, chemotherapeutics included, that are affected by the pharmacogenome. And I'll give one example. There's a common gene called DPYD. DPYD is a gene which affects the metabolism of a very commonly used class of chemotherapy agents, fluoropyrimidines. It turns out that if a patient has a mutation in that gene and they're given a fluoropyrimidine, fluorouracil, they're 30 times more likely to die of that treatment than if they didn't have the gene. And patients rarely do die from the treatment. So what a better world could we live in than the doctor and the patient know they have the gene before they get the treatment, not after. So that's just one example of how this will transform the safety and efficacy of treating oncology patients right here in the UAE. And it can only be done because all the sequencing has been done, and we're able to leverage the sequencing that's already been done and apply it directly to our patients.
So that's definitely a game changer in the world of oncology and the world of medicine in general, because there are other applications as well beyond oncology. So Dr. Val, in psychiatric treatment, which is another field that is not, I would say, very well understood, there are no biomarkers and we're still trying to figure out the best therapies for these patients. What are the applications of pharmacogenomics in psychiatric treatment?
Very interesting question, because many people in this world, they suffer from mental disorders, and I was surprised to read that 1 in 6 of Americans, they suffer from some sort of mental disability, and still the time which it takes to find the optimal drugs, it's really lengthy. And the most prescribed drug in psychiatric practice is antidepressant. However, the efficiency of the antidepressant, 38% only. FDA has a list of pharmacogenomics biomarkers which are associated with the drug label, and there are around 40 entities which is associated with the psychiatric care. And regrettably, testing for those entities is not considered at the standards of care. And definitely, we need to overcome certain barriers so we can improve. And basically, the optimal, I think, solution would be to implement pharmacogenomics, so we can definitely improve the psychiatric care. However, though barriers, one of those, we need to make sure that pharmacogenomics panels are standardized. Then obviously education, clinical education of the healthcare providers. I remember when in the US we start offering the pharmacogenomic testing, I think it was 2010, 2009, and certain physicians, they were ordering the test just because the patient asked them to do. And I remember the call when physician called me, okay, I ordered this test. Can you explain me the result? So now we're in 2025, but still education of health providers is extremely important. Then also in psychiatric care, there are still differences in the guidelines between psychiatric and genetic community. And there's still a question, is the use of pharmacogenomics in psychiatric care is cost efficient or not? Likely there is a light at the end of the tunnel because the recent study with CPIS, which is Clinical Pharmacogenomic Implementation Consortium, and they demonstrated, among other drugs, that 7 out of 11 antidepressants demonstrated high clinical efficiency and cost saving. So as soon as we overcome all those challenges, I think we will be in a much better shape. Thank you.
Thank you for commenting on the barriers, because definitely pharmacogenomics we've heard about them for a long time, but healthcare are slow to adopt. So, Dr. Grobmyer, in addition to the barriers that Dr. Val mentioned, what do you see as well in barriers, especially in the field of oncology?
From my standpoint, Val mentioned it, the biggest issue is educating the healthcare providers about how to use the information, because this is completely new for most of them. So what we've done actually is, I worked with Al Barad, M42, we actually recently obtained, as we implement at Cleveland Clinic Abu Dhabi, we obtained one of the pharmacogenomic reports, and I shared it with all the medical oncologists because, again, this is not something that they're used to looking at every day. Used to looking at pathology reports, radiology reports, genetic sequencing for germline and somatic genetics, but pharmacogenomic reports. And so doctors are busy. When they see new things they're not used to using, there's a reluctance to order them and use them. And so I think we have a big job to do to educate the workforce about the importance this can have in improving the safety of patient care.
And there's definitely a lot of stakes on the healthcare workforce, but as well, you definitely need the support of the regulatory bodies and professional bodies like the Emirates Pharmacy Society. So Dr. Dr. Amal, can you please comment on how the Emirates Pharmacy Society supports the initiative?
Yeah. We as Emirates Pharmacy Society encourage the implementation of the pharmacogenomics by advocating the policymakers and regulatories for implementing and adoption this system or this testing in our healthcare settings. We also empowering the pharmacists by educational sessions, webinars, certified programs. I myself attend one program, and it's worth to know more about this programs in our country. On the other hand, we can work also as Emirates Pharmacy Society in collaboration with institutions, hospitals, clinics, higher authority to apply the pharmacogenomic testing in our settings. Finally, I can also tell that we as Emirates Pharmacy Society encouraging the network collaborations for pharmacogenomic to exchange the experiences and the data between all over the Emirates and UAE settings and authorities.
Thank you. And a question to Dr. Sahar, Dr. Wadha. So, what does the future hold for the UAE in this field?
So we hope to make pharmacogenomics accessible for all, including the pediatric population, and to increase pharmacogenomic literacy among healthcare professionals, not only pharmacists, but physicians as well.
We also aim to utilize the data that has been generated from the Imarati Genome Program, where we've collected and sequenced more than 750,000 samples from our population, to be able to look into insights that might put our population more at risk in terms of how do they metabolize the medications or their risk for adverse drug reactions, and be able to implement a tailored pharmacogenomic report specific to our population and its needs.
Yes, Doc.
I would just like to add what we're looking forward to is the day when the doctor no longer has to order the pharmacogenomic test, but that it's generated for patients who are in the Emirati Genome Project, and that information is then fed into the electronic medical record, and that when we order a medication, an alert comes up in the computer and it says, based on the pharmacogenomic information that's now embedded in the EMR, doctor knows this should be over reduced dose or increased dose based on the pharmacogenomics. So to really make this really transformative, we need to get to the level where this is automated and really can make it easier for doctors to use.
Well, how far away do you think that day is?
I don't think it's that far. So what we're working right now with one of our healthcare operators is if a physician, is planning to order a certain medication, we're creating a pop-up alert. Okay, before you're prescribing this medication, undergo pharmacogenomic testing to be able to gain further insight, as well as if a pharmacogenomic report was generating, have a pop-up alert where they're able to understand, okay, this is available within the patient's electronic health record. Look at the data before you prescribe the medication itself. And like Dr. Stevens said, taking a step further, having this automatically be done before the patient is ever sick, having it available so that you don't have to also wait for the sequencing report to come out.
Yeah, I just want to relate to that. Interactive reporting definitely will help and improve the ease of working with the different data sets, and for physicians it's extremely important. Thank you.
Thank you to all our panelists for sharing insights and expertise. This has been very interesting. Thank you very much.